So, imagine a medication that is so potent it doesn't just treat a symptom, but it fundamentally reprograms the actual cellular factories inside your body.
Right, like a complete systemic override.
Exactly. And you likely know isotretinoin, or, it's often recognized by its original brand name, Accutane, as basically the absolute final boss of acne treatments.
Yeah, it really is.
It's this miracle drug that clears severe cystic acne when absolutely nothing else works. But the trade-off for that clear skin
hmm
is famously relentlessly dry lips, peeling skin, and, dry eyes.
And we culturally kind of just accept that extreme dryness as like the necessary toll for the cure.
Right, just deal with it for a few months.
Yeah, patients just carry their lip balm everywhere. They stock up on eye drops and they push through the 6-month course. But the clinical narrative usually stops right there, at the visible surfaces of the body.
Which leaves a massive blind spot, because what happens when that desert-level moisture depletion hits the mucous membranes of the reproductive tract?
Hmm.
Areas of the body that, frankly, nobody really wants to talk about. We have an incredibly revealing stack of sources for you today for our deep dive to figure out what is really going on here.
Quite a stack, yeah.
We are looking at clinical dermatology literature from Derm on Demand, a highly rigorous molecular study published in the journal PNAS, cross-sectional studies analyzing mucosal health, and active safety updates from the UK government's regulatory agencies.
And what's wild is these sources come from totally distinct corners of medicine.
Yeah.
You've got dermatology, molecular biology, gynecology, government regulation.
But they're all pointing at the same thing.
Exactly. They're all converging on this exact same biological mystery.
So our mission today is to uncover the exact cellular mechanisms behind how systemic isotretinoin therapy causes severe and potentially irreversible vaginal moisture depletion.
Which is a heavy topic for sure.
Yes. But before we get into the microscopic machinery of the cell, we really have to grasp the sheer scale of this in the real world.
Yeah, the numbers are, well, they're shocking.
Looking at the data from the dermatology literature, specifically the Exploring the Unseen report, it's jarring. Perigenital side effects are occurring in up to 40% of patients,
Wow.
and perianal symptoms in 26%.
Those numbers represent a massive portion of the patient population just experiencing profound discomfort.
Right.
We are looking at clinical manifestations that include severe dryness, irritation, microfissures, dermatitis, and like even bleeding in the affected areas.
I have to challenge those numbers, though, because 40%, that sounds unbelievably high for a side effect that isn't, plastered on a giant warning label on the box.
I know, it really does.
If nearly half the people taking this drug are experiencing severe genital bleeding or fissures, how do we know it's actually the drug?
Right, the correlation versus causation question.
Yeah, like teenagers are the primary demographic here. Couldn't this 40% just be capturing a mix of normal hormonal fluctuations, or maybe general skin sensitivity, or even, I don't know, a reaction to antibiotics they took before starting the isotretinoin?
It's a completely valid skepticism. And frankly, that same skepticism is exactly why this went undocumented for so long.
Oh, really?
Yeah, clinicians used to just dismiss these complaints as unrelated yeast infections or, friction from tight clothing.
Wow, just brushing it off.
Exactly. But the cross-sectional studies we're looking at, controlled for those variables, the data shows a direct temporal correlation.
Meaning the timing lines up perfectly.
Exactly. The symptoms start shortly after the medication begins, they peak when the dosage peaks, and they are entirely distinct from typical adolescent hormonal shifts.
Okay, so the data is solid.
Very solid. The reason it feels like a ghost symptom isn't because the data is weak. It's because the clinical environment inadvertently silences the patient.
Because it's an acne appointment.
Exactly.
You sit on the exam table, the dermatologist asks about your face, your lips, maybe your mood. They are absolutely not asking about your reproductive tract.
No. The clinical setting is incredibly compartmentalized. Unless a doctor explicitly asks, hey, are you experiencing any perigenital pain, dryness, or tearing? A patient is highly unlikely to volunteer that information.
Yeah, they're embarrassed.
They're deeply embarrassed. Furthermore, the average patient just has no reason to connect an oral pill prescribed for facial cysts to severe vaginal discomfort,
Right, they just think their body is betraying them in some new weird way.
which leads to this vast underreporting. The medical community basically treats the area as taboo by omission, and the patient suffers in complete silence.
Man, if you are listening to this and you've experienced that exact scenario, that 40% statistic proves you absolutely not alone.
Not at all.
Nearly half the people in that waiting room with you are likely dealing with the exact same hidden side effect. And understanding that scope really forces a much deeper biological question.
Yeah, like what is the drug actually doing to the tissue to cause that level of destruction?
Yeah.
To answer that, we have to look at what isotretinoin fundamentally does when it enters your system. The actodermatovenerologica report actually breaks down the precise molecular pathway.
Okay, lay it on me.
So isotretinoin is a prodrug.
Meaning the pill you swallow isn't the active compound doing the heavy lifting.
Correct. Your body has to process it first. Once it's absorbed, the isotretinoin molecule undergoes isomerization.
Isomerization.
Yeah, it physically rearranges its molecular shape into a different compound called all-trans-retinoic acid, or ATRA.
Okay, think of it kind of like a piece of paper. The pill you take is a flat sheet of paper,
Right.
but your body folds it into a paper airplane. The ATRA is the airplane, and it can now fly into the cell and actually do something.
I love that analogy, yes. That new molecular shape allows it to bind to very specific locks inside your cells, which are called retinoic acid receptors, or RRs.
Got it.
And once the ATR binds to the receptor, it upregulates a transcription factor known as FOXO3A.
Okay, we need to slow down here because transcription factor sounds like heavy textbook jargon.
Fair enough.
A transcription factor is essentially a project manager inside the nucleus of your cell, right? Its entire job is to read your DNA and tell the cell which genes to turn on and which ones to turn off.
That is spot on. And when FOXO3A gets activated by the drug, it gives a very specific, very aggressive order. It activates a protein called TRAIL.
TRAIL. TRAIL. What does that stand for?
It stands for tumor necrosis factor-related apoptosis-inducing ligand.
Okay, that is a terrifying name for a protein. Tumor necrosis factor.
Yeah, and it acts just as intensely as it sounds. TRAIL triggers something called the caspase cascade.
A caspase cascade.
Right. You can visualize it like a biological self-destruct sequence. It's this domino effect where one enzyme activates the next, literally snipping apart the structural proteins and DNA of the cell.
Wow.
Yeah, until the cell just neatly collapses in on itself. This process is called apoptosis, or programmed cell death.
So let me make sure I'm getting this. The drug isn't just like drying the skin out by evaporating water like a sponge left in the sun.
No, not at all.
It's actually delivering a targeted demolition order to the cellular factories themselves.
Exactly. And in the context of clearing acne, this mechanism is seen as a medical triumph.
Sure, because it kills the acne.
Right. The drug specifically targets the sebaceous glands, the oil factories in your skin. It induces apoptosis in the sebocytes.
Okay.
Dermatologists refer to this as extinguishing Kligman's oil of the acne flame. The factories die, the oil stops, the acne bacteria starve, and the skin clears up beautifully.
But a pill doesn't know it's only supposed to target your face or your back.
Exactly.
That trail demolition code gets broadcast through your entire bloodstream.
And this is where we see the collateral damage. Because trail doesn't discriminate. It also induces apoptosis in the cells of your mucous membranes.
Oh, wow.
The delicate homeostatic balance in your mucosal tissues relies on old cells dying and new moisture-producing cells constantly replacing them. But the drug fundamentally disrupts that equilibrium.
So the cells that are supposed to be producing lubricating mucus are instead receiving this chemical command to just self-destruct. Yes.
That perfectly explains the mechanism of the dryness itself. But, it brings up a massive biological contradiction for me.
What's that?
I understand an acne drug killing oil glands. That makes sense. But the female reproductive tract doesn't run on oil glands.
Right. It doesn't.
It relies on a completely different system for its structure, its health, and lubrication. So how is a retinoic acid drug crossing wires with reproductive tissue so severely?
That is the big question. And the PNAS study, the Proceedings of the National Academy of Sciences, provides the missing link here. And it is a truly fascinating piece of molecular biology.
Let's hear it.
The tissues of the female reproductive tract, including the vagina, cervix, and uterus, rely intensely on estrogen signaling.
Right.
Estrogen acts as the master architect for that entire environment. It signals the tissue to proliferate, to maintain a thick, healthy barrier, and to produce moisture.
So estrogen basically keeps the entire system online and functional.
Exactly. But the PNAS study reveals that retinoic acid directly antagonizes or blocks that estrogen signaling. Wait, hold on. Are you saying an acne pill is basically acting like an anti-estrogen drug in these specific tissues?
That is exactly what I'm saying.
But if the retinoid is blocking estrogen, why doesn't the body just, sense the blockage and pump out more estrogen to overpower it?
Because it's not a systemic hormone deficiency. Pumping out more estrogen won't help, because it's a localized physical blockade right at the DNA level.
Oh,
The study describes a phenomenon called genomic antagonism. Inside the nucleus of the cell, you have your estrogen receptors called DSR1.
okay.
You also have the retinoic acid receptors, the RAs we just discussed.
Right, the locks for the paper airplane.
Yes. And it turns out both of these receptors share the exact same transcriptional targets on your DNA.
Oh, wow. So they're literally trying to park in the exact same parking spots on the human genome.
Yes, it is a molecular turf war. Under healthy conditions, estrogen binds to those DNA targets and delivers the message, grow, produce moisture, stay resilient.
Right.
But when a patient takes systemic isotretinoin, massive amounts of retinoid just flood the system. The retinoic acid receptors competitively bind to those DNA targets, effectively stealing all the parking spots.
So the estrogen is completely locked out. Like you said, the body could produce all the estrogen in the world, but if the parking spots are full, the message just never gets delivered.
Never. And we already know the message the retinoid delivers instead.
Right. It upregulates FOXO3A, it triggers trail.
And it initiates apoptosis. So the cells in the vaginal and uterine lining are completely deprived of their survival signal from estrogen, and simultaneously they're being bombarded with a self-destruct signal from the retinoid.
Wow.
The tissue is forced away from a healthy, moisture-producing state and pushed towards stratification, where the tissue thins out, becomes highly fragile, and ultimately just dies off.
That completely recontextualizes the symptom. We aren't talking about a superficial dry patch here.
No, not at all.
We are talking about a drug overriding the dominant hormone in the reproductive tract at the genetic level, which forces us to look at really the primary goal of our deep dive today. When a patient finishes their 6-month course of isotretinoin, the retinoid leaves the system. Estrogen should theoretically get its parking spots back.
Right.
Does the tissue fully recover, or is this moisture depletion permanent?
Well, the question of permanence is currently the subject of intense regulatory scrutiny.
Really?
Yes. The UK government's regulatory agency, the MHRA, recently launched a very comprehensive safety review. Their documentation explicitly lists sexual dysfunction and vaginal dryness as known risks, but notes they are specifically investigating the possible persistence after treatment cessation.
Persistence after treatment cessation, meaning does the damage remain long after the drug is gone?
Exactly. And to understand if the reproductive mucosa can permanently lose its function, our sources actually point us toward a parallel tissue that undergoes a very similar trauma,
What tissue?
the eyes.
The eyes, okay.
Yeah. The ophthalmic data is alarming, but it offers the absolute clearest window into long-term mucosal damage. According to the medical literature, 83% of isotretinoin users develop dry eye.
Which, honestly, calling it dry eye feels like it minimizes the reality of what is happening.
It really does, because the dryness is actually caused by severe damage to the meibomian gland.
Right, and the meibomian glands, for anyone who doesn't know, are those tiny vertical oil-producing glands that line the inside of your upper and lower eyelids.
Yeah,
They secrete this specific lipid that basically coats your tears so the water doesn't just evaporate instantly.
exactly. And an interventional clinical study tracked patients taking isotretinoin and found a median meibomian gland loss of 34% occurring during the actual treatment window.
Wait, 34%.
Yes, the FOXO3A and trail pathways induced apoptosis in those specific ocular glands.
Okay, but a 34% loss. Are we talking about the glands just shrinking down and going dormant, or are they physically gone?
They are physically gone. Yeah, ophthalmologists use this specialized imaging technique called meibography. It utilizes infrared light to look beneath the surface of the inner eyelid and photograph the actual architecture of the glands.
Oh, wow.
In a healthy eye, the glands look like a long, uniform row of piano keys.
Mm-hmm.
But in patients who have taken systemic isotretinoin, the imaging shows permanent structural changes.
Permanent.
Yes, it looks like someone went in and just ripped out random piano keys. Entire sections of the eyelid are just empty tissue. They literally call it MG dropout.
MG dropout. So the glands died, they were cleared away by the body, and they are literally never coming back.
Never. And researchers are performing myopography on 45-year-old patients and finding this exact same pattern of permanent gland dropout 15 to 20 years after the patient stopped taking the acne therapy.
Oh my God. If this drug permanently eradicates over a third of the structural glands in the eyelid, and we know this drug operates systemically,
Mm.
does that mean the exact same physical dropout is happening in the glands of the reproductive tract?
It's honestly the most critical question in the literature right now.
Yeah.
Clinical experience does indicate that for many patients, the acute symptoms of vaginal dryness do improve once the drug is stopped.
Right. The estrogen rebinds, the tissue attempts to heal, and some function returns.
Exactly. However, the permanent architectural changes documented in the eyes strongly suggest that some degree of mucosal atrophy in the reproductive tract may be entirely irreversible.
Wow.
If a moisture-secreting gland in the vaginal mucosa undergoes apoptosis and drops out, the biological precedent tells us it just does not regenerate.
Which is exactly why the UK government is actively investigating the long-term persistence.
Yes.
And this is why this information is so vital for you as a patient or, as a parent. When you weigh the risks of a treatment, knowing whether a side effect is just a temporary inconvenience or a permanent structural alteration, that completely changes the calculus of medical decision-making.
It absolutely redefines informed consent. Patients need to know that the medication acts on an active cellular demolition pathway.
So, if someone listening to this is currently dealing with this severe moisture depletion, whether they are on the drug right now, or maybe they are years out and dealing with the ghost symptoms of potential glandular dropout, what does the clinical science say about finding actual relief?
Well, according to the clinical guidance from our member source, the frontline approach really focuses on mechanical restoration.
Mechanical restoration.
Yeah, meaning patients require the consistent use of high-quality moisturizing creams formulated specifically for the vaginal mucosa. You are essentially stepping in to manually provide the protective barrier that the cells are no longer maintaining themselves.
Okay, but based on the molecular mechanism we just explored, the root cause is an estrogen blockade.
Right.
Wouldn't the most effective treatment be applying a topical estrogen cream directly to the area to help the tissue fight back and reclaim those DNA parking spots?
It is a very logical conclusion.
Yep.
And from a purely mechanistic standpoint, localized topical estrogen can be highly effective at reversing mucosal atrophy.
Because it directly combats the genomic antagonism caused by the retinoic acid.
Exactly. However, estrogen is a very potent cellular growth signal. It tells tissue to proliferate. And while that is great for healing a microfissure, it is highly dangerous if a patient has abnormal cells present.
Oh, because certain cancers, like estrogen receptor-positive breast cancer, use that exact same growth signal to multiply and spread.
Exactly. For a patient with a personal or even a family history of hormone-driven cancers, utilizing topical estrogen is often totally contraindicated. It just poses too high of a systemic risk.
That makes sense.
That is why non-hormonal therapies are emphasized as a critical, much safer alternative for many patients.
Okay.
Advanced non-hormonal moisturizers can significantly alleviate the physical friction, they prevent the micro-tearing, and they reduce the pain associated with mucosal depletion, all without introducing a systemic hormonal risk.
But it really requires a highly individualized approach with a doctor who actually understands the root cause of the dryness, rather than someone who just assumes it's a generic infection.
Exactly. The clinical dialogue just has to change from assumption to targeted investigation.
Looking at everything we've covered today, the journey of the single pill through the human body is just staggering. We started with a taboo side effect, this severe paragenital and perianal dryness that is quietly affecting up to 40% of patients.
Yeah. And then we zoomed into the nucleus of the cell to observe isotretinoin transforming into ATRA, activating FOXO3A, and triggering that trail protein to initiate a targeted sequence of cellular self-destruction.
And we watched a literal molecular turf war unfold as retinoic acid hijacked the DNA targets meant for estrogen, effectively starving the reproductive tract of its primary growth and moisture signal.
And finally, we analyzed the really alarming permanence of meibomian gland dropout in the eyes, which highlights the very real possibility that some level of mucosal atrophy in the reproductive tract may persist for decades.
It is just a masterclass in how interconnected our biological systems are. You cannot fundamentally alter the oil production on the surface of the face without sending shock waves through the delicate ecosystems deep within the body.
No, you really can't.
But before we finish up today, there is one final lingering concept that the sources point toward. Something for you to mull over that we haven't fully explored yet.
Yeah, and it really comes down to the timing of the intervention.
Yeah.
Because the vast majority of systemic isotretinoin prescriptions are written for teenagers.
Right.
This medication is introduced right as their bodies are in the throes of massive, hormone-driven developmental changes.
Puberty.
Exactly.
The exact window of time when estrogen is supposed to be working overtime, basically laying down the foundational architecture of the reproductive system for adulthood.
So consider this. If retinoic acid aggressively blocks estrogen signaling and induces cellular apoptosis in these specific tissues, could a standard 6-month course of this medication during puberty do more than just cause temporary dryness? Could it permanently alter the developmental trajectory of stem cells in the reproductive tract for the rest of a patient's life?
Are we literally interrupting the biological blueprint while the foundation of the house is still being poured? It is a profoundly unsettling question to consider the next time you hear someone casually mention a simple cure-all pill for acne.